We looked at ibrutinib maintenance in patients who were treatment naive and required intensive induction therapy to begin with. So patients could be treated with chemoimmunotherapy with or without an autologous stem cell transplant. And for those who achieved a complete response or a partial response, they could be enrolled on the trial and receive ibrutinib maintenance at a dose of 560 milligrams daily for up to 4 years or until disease progression or intolerability. And what we found was, so we accrued 36 patients, and accrual is complete. And in these 36 patients, I think it's important to note that these patients actually had some high-risk features. Over 3/4 of our patients actually had advanced stage disease. Half of our patients actually had either an intermediate or a high-risk MIPI. 25% of our patients actually had extranodal disease. When we sort of look at the treatment patterns here, which is sort of interesting, 47% of our patients actually were treated with BR up front, 25% were treated with our hyper-CVAD, and the remaining were treated with our CHOP with or without cytarabine-containing cycles. With induction alone, 33 out of our 36 patients actually achieved a CR. So that sort of supports the idea that we can get high response rates with induction chemoimmunotherapy alone. It is important to note that 50% of our patients actually did get an autologous stem cell transplant, so that plays into the high response rates. There were 3 patients who actually had a PR. So with our 36 patients who went on to ibrutinib maintenance, there was actually 1 conversion of a PR to a CR, and of the remaining 2 patients in PR, 1 stayed in PR, and then 1 patient had progression of disease. We were able to actually feasibly give ibrutinib maintenance for a prolonged period of time. So far, we have 19 months of follow-up, and with 19 months of follow-up, 24 out of the 36 patients continue to be on ibrutinib maintenance, which sort of speaks to the feasibility of ibrutinib maintenance.